Basically trick of the trade is when you pull the this round ligament or the ductus venosus where it continue as the ligamentum venosum, you will will be applying traction on the left portal vein. You can easily identify the left portal vein in difficult anatomy with the help of this maneuver. Hello everyone. So this will be eighth video in our people series, and in this short yet crucial video, we will discuss an important surgical technique that helps to reduce the risk of post-Whipple hemorrhage. We will also cover the types of post-Whipple hemorrhage and strategies for early detection and prevention. So this is a critical trick of the trade and Whipple surgery that every surgeon should master. I hope that you have already watched the previous 7 episodes in this series. If not, do watch them now to have a comprehensive understanding. And for a exclusive and early access to our premium high definition content, you can download our app available for Android and iOS or join the channel membership. The link for everything is given in the description of this video. So friends, the major cause of mortality after any pancreatic surgery or for that matter Whipple surgery is post-pancreatic pancreatectomy hemorrhage, and the usual cause after Whipple is the gastroduodenal artery stump. I have given a reference to a paper in this part of the video. All of you can read this. This is a free to download paper on PubMed, and that is by Bessie et al. Post-Whipple hemorrhage are basically two types, early and late. The early hemorrhage occurs within first 24 hours after the surgery, and it is usually due to surgical bleeding or incomplete hemostasis. Having said so means that if this is a technical failure, means we have as a surgeon one has failed to basically ensure adequate hemostasis. We should always try to avoid this complication. We should ensure proper hemostasis as we have discussed in the previous video, and we will discuss more in the upcoming videos. It will present as a tachycardia, hypotension, and frank blood in the drains. The usual recommendation is to do a early re-exploration and ensure hemostasis, or you can follow the endovascular intervention also. But usually our policy or recommendation is to do a early re-exploration to ensure hemostasis. Second type of hemorrhage post-Whipple will be delayed post-operative hemorrhage, and usually it occurs in between 5 to 10 days after the surgery. It is most commonly arterial in origin, often from the GDA stump blowout. Basically, GDA stump is very close to the pancreatic osteostomy anastomosis. There is a leak, infection, there are pancreatic enzymes leaking that lead to a pseudoaneurysm and blowout of the stump. And usually it is a very troublesome or dreaded complication that can be fatal also. And it requires urgent angiography and embolization, and in severe cases, surgical re-exploration. So the first method in the early hemorrhage, our recommendation is to re-exploration and hemostasis. For late hemorrhage, the first approach will be endovascular, that is you do a DSA and coiling of the GDA stump. How to safeguard the GDA stump, how you should ligate, how much should be the length. We will discuss everything in the upcoming videos, so stay tuned. Keep this point in your mind that whenever patient of Whipple is recovering well, like maybe 5 to 7 days post-operative period, patient is having pancreatic fistula also, and suddenly there is a drop in the blood or there is sentinel bleed. But a sentinel bleed, there is a minimal bleed in the drains, patient is doing well. So you always suspect, friends, always suspect GDA stump hemorrhage in the post-Whipple patient with delayed bleeding symptoms, and be very, very suspicious, be very, very careful. So as a part of the prequel to the falciform ligament, I have already covered in detail about a short video in our Tricks of the Trade in GI Surgery series. I am sharing short clip as a theoretical rationale for your benefit. And in this article, they have given a very good technique of wrapping it in a detail. All of you should read this article. Again, this is a free PubMed index article. Here is the part of the video I am sharing from the previous Tricks of Trade in GI Surgery. So this is going to be the third video in our Tricks of the Trade in GI Surgery series, and the topic for this short video will be falciparum. So in this short video, we will demonstrate and discuss theoretically how to tackle the falciparum while doing the laparotomy. So in this pictorial depiction, friends, we will demonstrate in the live surgery also. So after the laparotomy that you have given incision and we have gained access into the abdomen, While going up towards the basically xiphoid, you corner the falciparum. So friends, the trick of the trade here is that you have to always go from the left side of the falciparum as depicted by the arrows here, and this line diagram which I have drawn. I hope you'll find it useful. So falciparum will be separated from the peritoneum. There's an attachment on the left side and then the right side, and it usually results in the bloodless entry of the abdomen. So friends, these are small tips and tricks, and these are the things which we have learned over time, and some of these tips were taught by our seniors. So for the benefit of junior trainees, we are sharing with you. So in the next part of video, we will demonstrate the live surgery, and you can watch this complete video in our Tricks of Trade and GI surgeries. So now friends, I'll give you some few points or pearls of the wisdom and anatomical insight into the falciparum ligament. So basically, falciparum ligament is a remnant of the ventral mesentery. It attaches liver to the anterior abdominal wall, and it is made of the two layers of peritoneum where it reflects on the falciparum ligament. Other terms the trainees has to understand is the round ligament of the liver. It is the obliterated left umbilical vein of the neonate. It is part of the fetal circulation which bypass the blood, and it runs in the free edge of the falciparum ligament. So, falciparum ligament in the free edge there is a cord-like whitish structure that is actually the round ligament of the liver. So basically, the falciparum ligament arises at the umbilicus. That all of you understand the fetal anatomy, and it arises at the umbilicus and continues towards anterior aspect of the liver in continuity with the umbilical fissure. So from the umbilicus to the umbilical fissure, there is a falciparum ligament. From there, the falciparum ligament courses cranially, and it basically merges or reflects on the left and right coronary ligaments and merges with the Gleason capsule. So it is all one peritoneal covering which is merging with the Gleasonial capsule and the right and left coronary ligaments. That is the falciparum ligament. Basically, you can say insertion or the attachment. The important point you can remember is that at the base of the falciparum ligament, basically where it attaches and reflects on the right and left coronary ligament, it is the site for the hepatic veins and the IBC, where all the three hepatic veins, right, left, and middle, drains to the IBC. So there's another landmark that where the at the base of the falciparum ligament, where it is getting reflected on the coronary ligament, it is the site of the major hepatic veins and the IBC. So as I said, in the free edge of the falciparum, there is the round ligament. It's also called ligamentum teres, round ligament. It is part of the obliterated umbilical vein or ductus venosus. So this one thing is known by many things, that is the ductus venosus, obliterated umbilical left umbilical vein, ligament teres or round ligament of the liver. So it is the obliterated left umbilical vein from where from the basically umbilical fissure it attaches or continue into the left portal vein. It is called ligamentum venosum. Initially it was called ductus venosus, then ligamentum venosum. So it is a continuation of the ductus venosus. It is called as the ligamentum venosum, where it attaches the left portal vein. Also, do remember that usually it is obliterated. Our policy is to tie it properly, and specifically in case of portal hypertension, it can be the part of the collateral circulation through abdominal wall. So it get recanalized. So ductus venosus of the left umbilical vein get recanalized, and if not tied properly during laparotomy, that can be cause of the source of troublesome post-operative hemorrhage. So with that, we have reached the end of this video. I hope the technique which we shared and the pearls of wisdom which we have shared with you will be helpful. And if you're watching this video on our YouTube channel or on our app, don't forget to like and do subscribe to our channel for all the future updates. I'll see you soon with a new episode in the Whipple series. And I'm sharing basically all the main cards of the Whipple series here at the end of this video. And don't forget to check them out. So thank you very much, friends. Happy learning. Stay tuned.